You know, it's funny. Usually when we talk about some kind of medical diagnosis, right, there is this expectation of precision.
Oh, yeah, absolutely. Like it's engineering or something.
Right. You break your arm, you go into a clinic, they take an x-ray, and you get this very definitive, jagged white line on a black background.
Right. And the doctor just points to it and says, well, there is the problem.
Exactly. It's a binary way of looking at health. The bone is either broken or it's intact.
Yeah, we are so conditioned to expect our medical issues to be visible,
Right.
like easily categorized.
But then you step into the world of chronic, mysterious muscle pain, and suddenly that x ray machine is completely useless.
It really is. It gives you nothing.
You are looking at a diagnostic landscape that is just incredibly murky. I mean, it can feel like you are chasing a ghost.
That is honestly the perfect way to describe it. Soft tissue pain, especially when it becomes chronic, it just does not show up on a standard radiograph.
Right.
It doesn't easily offer up that physical evidence that a patient can point to, which, makes the diagnostic process highly subjective.
And often very frustrating.
Oh, incredibly frustrating for both the patient and the clinician, really.
And I want to speak directly to you, our listener, because we are diving deep into your personal notes today.
Yeah, we've got a lot of ground to cover.
We really do. We are looking at this incredibly frustrating battle you have been fighting for, the last 2 months, with this left-sided lower back pain.
Which is such a difficult area to treat.
It is. And reading through your notes, what really stood out to me is how maddeningly inconsistent this pain has been for you.
Yeah, the patterns you documented, they describe a very specific, almost paradoxical type of discomfort.
Like you wrote that the pain disappears depending on your posture.
Which sounds crazy to some people, but it's a huge clue.
Right. Because, for instance, you somehow have absolutely no pain when you are out on your morning runs.
Which is great, by the way.
Yeah, you actually feel totally fine when you are moving around. But the second you sit down at your desk to do your work, it just becomes agonizing.
Yeah, the transition from dynamic to static.
It's the kind of pain where you are constantly shifting in your chair, right? Like trying to trick your body into feeling comfortable, and literally nothing seems to work.
Which is an incredibly common presentation for certain muscular issues. But it's also deeply isolating.
Isolating how? Like psychologically?
Yeah, psychologically and medically. You go into a clinic, you look completely healthy, you are clearly active because, you are still running every morning.
Right, you don't look injured.
Exactly. You have no visible injury. So it is very easy for that kind of pain to be dismissed or misunderstood by doctors.
And you mentioned you have been on the whole medical merry-go-round trying to fix this.
Trying everything.
Literally everything. You tried electrical therapy, you took general pain pills, which you noted you really did not want to do.
Which is completely understandable.
You got private massages, and in your own words, you were essentially like deceiving yourself into thinking the pain was getting better when it really wasn't.
A very common cycle. You get an hour of relief and think it's cured.
Exactly. Until finally you had a turning point.
The visit back to the trusted orthopedic clinic.
Yes. You went to see the senior doctor, who you affectionately call O-sensei, someone you have known for nearly 30 years.
Having that established trust is so huge in medicine.
It really is. And what is interesting is that O-sensei did not just look at a chart or, throw more general pain medication at you.
He actually put his hands on you.
Yes. He palpated your back. He used his hands. He found this massive hard lump of muscle deeply buried on the left side.
The literal root of the problem.
And he introduced you to a specific intervention, which is the trigger point injection, or TPI.
And based on your notes, the relief following that intervention was substantial.
Substantial is an understatement. You wrote that you had an 80% reduction in pain almost instantly.
Which is incredible.
It is. But now, of course, you have a whole new set of questions. Because while the left side is finally giving you some peace, a brand new problem has cropped up.
Of course it has.
Now your right side is starting to hurt.
Well, the body is a complex, interconnected ecosystem. When one part undergoes a major shift, the rest of the system reacts.
Right. It's trying to find a new balance. So our mission for this deep dive is to map out this ecosystem for you.
To give you the mechanical blueprint of what's happening.
Exactly. We are going to address your specific questions about this whole journey. We need to figure out what exactly was inside that syringe.
The pharmacology is fascinating.
What are the true biological mechanisms that make this injection so different from all the other treatments you tried?
Why it works when a massage fails, essentially.
Right. And crucially, moving forward, Can this exact same treatment be used to tackle this new right-sided lower back pain?
To get those answers, we are synthesizing some really fascinating source material today.
We've got a great mix of sources,
We do. We have your personal medical essays and your actual clinic receipts.
which is so helpful.
It details the exact medications the clinic used. And we are combining that personal data with comprehensive clinical guidelines from the NCBI.
The National Center for Biotechnology Information.
Exactly. Specifically focusing on their medical texts regarding the administration and pathology of trigger point injections.
Okay, let's start at the beginning. Because before we can understand why that injection gave you such massive relief, we really have to understand the physical abnormality it was attacking.
The monster under the bed, so to speak.
Right. When O Sensei pressed on your back and found that hard lump, what exactly was he touching? Because to the average person, if a muscle hurts, it just hurts. A muscle is a muscle.
Well, from a clinical perspective, there is a distinct pathology at play here. What O Sensei located was not just a generic sore muscle,
Okay.
it was a myofascial trigger point. And to fully appreciate what that term means and why it matters, we actually have to look back at the medical history,
How far back?
specifically to the year 1942.
1942. That seems like a very specific and honestly fairly old starting point for modern back pain.
It is a crucial milestone, though. This was the year a physician named Dr. Janet Travel first formally described the concept of myofascial trigger points in the medical literature.
Oh, wow. So before her, what did doctors think this was?
Well, before her work, the broader medical community didn't really have a unified vocabulary for this highly specific type of muscular dysfunction.
They didn't even have a name for it.
Not really. Patients would come in with these deep, aching pains, and doctors would often just use umbrella terms like muscle strain or rheumatism or lumbago.
Lumbago. I feel like you only hear that in old Western movies now.
Yeah, and lumbago basically just means lower back pain. It's not a diagnosis, it's just a symptom.
So it was just a catch-all bin for anything they couldn't see on an x-ray.
Essentially, yes.
Yeah.
But Dr. Travel identifies something highly specific and localized.
What did she find?
Well, the NCBI guidelines we are looking at define a trigger point very carefully based on her foundational work. It is described as a thurcle, hyperirritable knot located within a taut band of skeletal muscle.
Okay, wait, I want to break down that terminology. A taut band.
Yeah.
Are we talking about something like a guitar string that has been pulled far too tight?
Actually, that analogy works really well visually.
Okay.
If you imagine the architecture of a healthy muscle, the fibers are supple. They're designed to glide over each other smoothly as the muscle lengthens and contracts.
Like sliding glass doors or something.
Right. But in a taut band, a specific localized length of that muscle fiber has become functionally rigid.
Rigid, okay.
It feels almost cord-like under the skin. And within that rigid cord, there is an even more concentrated focal point, a nodule or a knot.
And that knot is the trigger point.
That is the actual trigger point itself, yes.
I want to stop and look at this from the listener's perspective for a second, because I imagine anyone who has ever had a tough workout or maybe just slept in a weird position is thinking, well, isn't a trigger point just the medical phrase for a normal tender muscle?
It's a common misconception.
Right, because I get sore muscles all the time.
Yeah.
Why does this need a specific classification from 1942?
The clinical distinction is vital, and the NCBI text makes a point to emphasize this exact difference because the two are very frequently confused in everyday language.
Okay, so what is the dividing line between them? How do you know which one you have?
It basically comes down to how the pain behaves when provoked. A tender point only produces pain directly at the site of palpation.
Meaning where you touch it.
Right. If I press my finger into your shoulder and you have a tender point there, you will feel discomfort exactly where my finger is applying pressure.
Like pushing on a bruise.
Exactly like pushing on a bruise. The pain does not travel. It is a localized, normal response to minor tissue strain.
That makes perfect sense. It behaves the way you expect an injury to behave.
But a trigger point operates completely differently.
Yeah.
When a clinician applies sustained pressure to a true trigger point, it produces what is called characteristic referred pain.
Referred pain. So the pain is essentially traveling away from the actual knot.
Yes, exactly. You might press on a localized knot deep in the lower back, and suddenly the patient feels a deep, aching pain radiating down into their buttocks,
How?
or wrapping around their hip, or even traveling down the back of their leg. The physical pressure on the knot literally triggers a sensory response in a completely different geographical location on the body.
That sounds incredibly confusing for the patient. You feel the pain in your hip, so you assume your hip is the problem.
Naturally,
But the actual source is a knot 3 inches higher up in your back.
it is a major reason why these issues go misdiagnosed for so long. People get treated for hip bursitis when the problem is in their back.
That is wild.
It is a complex neurological phenomenon where the central nervous system essentially misinterprets the origin of the distress signals.
Like cross wires in a fuse box.
Exactly. Furthermore, the NCBI guidelines note another unique characteristic. Pressing a trigger point often elicits a local twitch response.
A twitch.
Yeah, the muscle fibers literally spasm or twitch involuntarily under the examiner's fingers.
An involuntary twitch. Like the muscle is actively trying to pull away from the pressure.
It is a spinal reflex. And crucially for our listener, who noted that their pain was agonizing when sitting at a desk,
Right, the desk pain.
these trigger points physically restrict the range of motion of the involved muscle.
Oh, because it's locked up.
The muscle cannot reach its full natural length because that fibrotic knot is anchoring it in a shortened state.
So when our listener was trying to sit down and do their work, that taut band in their lower back was acting like a physical tether.
That's a great way to put it.
It was preventing the muscles from stretching out naturally, which turned a simple seated posture into an active physical struggle.
And in the context of lower back pain, we see these specific trigger points form very frequently in the architectural muscles of the posterior chain.
The posterior chain being all the muscles down the back of your body.
Right. Often clinicians are looking at the quadratus lumborum.
Okay, the quadratus lumborum, where is that?
It's a deep foundational muscle that connects your lowest rib to the top of your pelvis. It stabilizes your entire core.
Got it.
They also look closely at the gluteus medius, which sits on the outer surface of the pelvis and is heavily responsible for stabilizing your hips during movement.
Okay, that anatomical context explains so much of the listener's notes.
Doesn't it?
Yeah. They mentioned they had absolutely no pain when they were out for their morning run.
Right.
When you are running, the gluteus medius and the quadratus lumborum are engaging dynamically.
They're pumping.
They are moving in a rhythmic pattern, allowing blood to flow in and out. But when you sit down at a desk,
You are demanding that those exact same muscles hold a static isometric contraction to keep your torso upright against gravity.
the mechanical demand changes entirely.
It really does. A dynamic movement allows for brief periods of relaxation between contractions. A static, seated posture demands an immense amount of continuous endurance from a muscle.
And if that muscle is already harboring a taut band and a trigger point,
That static hold quickly becomes unsustainable. It just burns out.
okay, so we understand the physical reality of the knot. We know what O-sensei felt under his hands. But the notes mention O-sensei explaining that this knot creates a vicious cycle.
Ah, yes, the cycle.
He told the listener that an injured muscle tenses up, which worsens the blood flow,
Right.
which in turn causes more pain, which then causes more tension. It just loops.
That is the fundamental pain, tension, ischemia cycle. Ischemia referring to a localized restriction in blood supply.
But to truly grasp why this cycle is so stubborn, I mean, why a massage or a pain pill couldn't fix it for 2 months.
You have to look deeper.
Yeah, I feel like we need to zoom way, way in. We need to look under the microscope at the actual cells. What is happening biologically inside that top band?
Well, according to the StatPearls research provided to your sources, the underlying pathogenesis, meaning the biological origin of this dysfunction, is heavily tied to abnormalities at the motor end plates.
The motor end plate, let's define that for a second. That is the junction where the nerve physically connects to the muscle fiber to tell it what to do, correct?
That is the basic mechanism. It is the communication bridge.
Okay.
In a healthy system, the brain sends a signal down the nerve, the motor end plate releases neurotransmitters, the muscle receives the chemical message, and it contracts.
Like flipping a light switch.
Very much so. And when the signal stops, the muscle relaxes. It is an elegant, highly efficient biological switch. But in the environment of a trigger point, this switch basically malfunctions.
Malfunctions in what way? Is it like ignoring the signal or is it getting too many signal?
Definitely the latter.
Yeah.
Clinical electromyography or EMG studies.
Wait, EMG, what is that exactly?
It involves inserting tiny electrodes directly into the muscle to measure electrical activity.
Oh, so they are actually listening to the muscle's electrical output.
Exactly.
Yeah.
And these studies reveal that these specific trigger points exhibit spontaneous electrical activity.
Spontaneous.
Yes.
So the muscle fibers are firing and contracting on their own, even when the brain is not consciously telling them to move.
They're constantly generating action potentials. The nerves and the nociceptive pain fibers in that microscopic region become highly sensitized and hyperactive.
Just constantly buzzing.
Right. This leads to what is called enhanced central sensitization in the spinal cord.
Enhanced central sensitization. Okay, what does that mean for the patient?
The spinal cord essentially starts overreacting to these local signals. It amplifies them, creating a localized feedback loop of continuous neural activation.
So if the nerve is constantly firing, the muscle is essentially receiving a screaming command to contract 24 hours a day, 7 days a week.
And we have physical proof of this. Histological evidence, which comes from taking actual physical biopsies of this tissue and looking at it under high-powered microscopes, shows severe muscle hypercontraction.
Wow, they actually cut out a piece of the knot to look at it.
They have in studies, yes. And they see that the foundational contractile units of the muscle, which are tiny protein filaments called actin and myosin,
Actin and myosin.
they are physically locked together in a highly shortened state.
Okay, but what is physically holding them in that locked position? I mean, there has to be a chemical trigger keeping those actin and myosin filaments glued together.
You're right. The core biological driver of that lock is calcium,
Calcium, like what's in milk?
the very same ion, yes. The NCBI literature highlights that this continuous, spontaneous neural activation causes a sustained release of calcium ions from a cellular structure known as the sarcoplasmic reticulum.
The sarcoplasmic reticulum, we need to break that down because it sounds incredibly complex.
It's quite a mouthful.
What is its normal job in the muscle?
You can think of the sarcoplasmic reticulum as a microscopic storage tank situated inside the muscle cell.
Okay, a storage tank.
Its sole job is to hold onto calcium. When a normal nerve signal arrives, the tank opens, flooding the area with calcium, which acts as the chemical key that allows the actin and myosin to bind together and contract.
So the calcium is the key that turns the engine on.
Exactly. Once the contraction is done, the cell rapidly pumps all that calcium back into the storage tank, which allows the actin and myosin to release.
Okay, but in the trigger point, because the electrical signals are firing spontaneously and constantly.
That storage tank never gets the chance to close.
Oh.
The environment is continuously flooded with calcium. The actin and myosin filaments are chemically forced to remain locked in that contracted state.
I'm trying to visualize this continuous lock on a slightly larger scale to make sure I'm following the mechanics. It almost sounds like a massive traffic jam on a highway.
How do you mean?
Well, imagine the muscle fibers, the actin and myosin, are cars traveling on a multi-lane highway.
Okay, I see where you're going.
Usually, they glide past each other smoothly. But this spontaneous nerve firing and the massive flood of calcium acts like a multi-car pileup.
Yes.
The cars, the fibers are suddenly gridlocked. They are wedged together so tightly that they literally block the lanes.
They block the physical space.
Right. And because the highway is physically blocked, the supply trucks can't get through.
The supply trucks being the vascular system in this analogy.
Right, exactly. The fresh blood carrying oxygen and vital nutrients cannot penetrate the gridlock.
It's walled off.
And equally importantly, the garbage trucks cannot get in to clear away the debris
The metabolic waste. That is a very apt way to describe the localized ischemia.
because the muscle is still trying to work, right?
Yes, when a muscle is constantly contracting, it is burning energy and producing metabolic byproducts.
Exhaust fumes, basically.
Right. Without adequate blood flow to flush those byproducts away, you get a localized pooling of lactic acid and various inflammatory cytokines.
So you have a gridlocked highway that is rapidly filling up with toxic acidic exhaust. That sounds incredibly painful.
It creates a highly acidic, noxious environment. This toxic soup chemically irritates the local sensory nerves, which then send massive, urgent pain signals back to the central nervous system.
Which brings us right back to Osensei's cycle.
The loop closes.
The brain receives these massive pain signals, assumes the area is under severe threat, and its natural protective instinct is to say, brace yourself, lock down the area so we don't cause further damage,
Which causes the brain to send even more signals to the motor end plate,
which releases more calcium,
which locks the muscle fibers even tighter,
which cuts off even more blood flow.
which creates even more acidic waste. The loop is closed. The muscle is biochemically trapped.
Wow, that entirely explains why our listener was so frustrated.
It's impossible to stretch your way out of that.
Right. They were taking oral pain pills. They were trying to stretch it out. They were using electrical pads on the surface of their skin.
None of which penetrates to that depth.
But none of those interventions were capable of clearing a deeply entrenched cellular traffic jam. You can't fix a biochemical calcium lock by just bending over and trying to touch your toes.
Superficial interventions cannot break a microscopic mechanical lock.
Which brings us to the intervention that actually worked.
The trigger point injection.
Yes, O-Sensei's TPI. Let's look at the exact mechanics of this procedure. Because how does a single syringe manage to shatter this deeply entrenched biological crisis?
To understand the efficacy of the TPI, we actually have to separate the procedure into two distinct parts.
Okay.
There's the mechanical action of the needle itself, and then the chemical action of the medication.
So the needle is doing work before the medicine even comes out.
Exactly. The NCBI guidelines make it clear that the physical needling is a therapeutic mechanism all on its own.
So the needle is not just a delivery vehicle for the medicine, it is a physical tool.
It is a tool for mechanical disruption. The guidelines detail the specific technique required.
What does that look like?
The clinician typically selects a fine needle, usually ranging from 27 to 30 gauge.
Just to give you context, a 30 gauge needle is extremely thin, right?
Very thin, almost like a heavy acupuncture needle. The clinician generally inserts it into the skin at roughly a 30-degree angle.
But they don't just insert it once and push the plunger, right? Because they are trying to break up a three-dimensional knot.
The technique requires precision and movement. The clinician will first palpate the area to isolate the exact location of the taut band.
Okay, they find the knot.
They often use a pincer grip with their non-dominant hand, squeezing the muscle to hold the trigger point steady.
Just trapping it so it can't slide away.
Right. Once the needle is inserted into the knot, they perform a rhythmic, piston-like motion.
A piston-like motion, meaning they're pulling it in and out of the muscle.
They repeatedly insert and partially retract the needle, subtly changing the angle of trajectory with each pass.
Like fanning it out.
Moving in multiple directions within the targeted knot, yes. And they do this without completely withdrawing the needle from the skin.
Wow. They are physically probing and manually breaking apart the fibrotic tissue.
Yes.
It is essentially like using a microscopic crowbar to pry apart the jammed cars in our traffic analogy.
And clinicians rely heavily on tactile feedback during this process.
Tactile feedback, meaning they can feel what's happening through the needle.
As they perform this rhythmic fanning motion, they can often feel a distinct sensation transmitted up through the needle. It is frequently described in the literature as a crunching or a pulling sensation.
A crunching sensation inside the muscle. Ugh.
It's very distinct.
That sounds intense, but I can also see how it would be necessary to physically break the adhesions.
It is the physical resistance of the hypercontracted fibers and the surrounding restricted fascia yielding to the needle.
So they are literally tearing the microscopic glue apart.
The clinician continues this rhythmic needling until they feel that crunchy resistance give way to smooth tissue.
Like pushing a needle through a cork until it hits soft butter.
Exactly. And they continue until they observe that the local twitch response we mentioned earlier has completely subsided.
So they mechanically force the muscle to stop spasming. That covers the physical disruption.
Right.
But I want to talk about the chemical payload, because this is where having the listener's actual medical receipt is so valuable.
It takes all the guesswork out of it.
We don't have to guess what was in the syringe. We have the exact pharmacology. Let's read directly from the receipt.
What did it say?
It lists two primary components. The first is 3 milliliters of a solution called xylocaine, 0.5%.
Okay.
And the second is an ampoule containing 4 milligrams of something called Rinderon, listed as a 0.4% injection solution. Let's tackle these one by one. What is Xylocaine?
Xylocaine is simply a widely used brand name for the generic drug lidocaine.
Lidocaine. Okay, that is the same medication the dentist uses to numb your mouth before filling a cavity, isn't it?
It belongs to the exact same class of drugs, local anesthetics.
Okay, so it just numbs the area.
Right. Its primary pharmacological function is to temporarily block voltage-gated sodium channels in the cell membranes of local nerve endings.
Okay, let's slow down on the chemistry there. What is a voltage-gated sodium channel, and why does blocking it stop the pain?
When a nerve needs to send a pain signal to your brain, it does so by creating an electrical charge.
Like a battery.
Exactly. It generates this charge by rapidly opening tiny channels in its membrane, allowing positively charged sodium ions to rush into the nerve cell.
Okay.
This creates an electrical wave that travels up the nerve to the brain. Lidocaine molecules physically wedge themselves into those sodium channels, plugging them up.
So if the sodium can't rush in, the electrical wave can't form.
Right.
And the nerve physically loses the ability to transmit the pain signal. The area just goes completely numb.
The signal is completely intercepted at the source.
But why is it necessary to numb the muscle knot? Is it just to make the patient more comfortable, or is there a therapeutic reason?
Comfort is a massive part of it. The mechanical disruption we just discussed,
The pistoning and the crunching.
that causes localized microtrauma, it is a painful process.
I can imagine.
By flooding the area with lidocaine, you provide immediate, profound relief from the procedural pain. The NCBI text actually compares this directly to a procedure called dry needling.
Dry needling being the exact same mechanical process, but using a needle with an empty syringe or just a solid acupuncture needle.
Correct. The literature shows that while dry needling is highly effective at mechanically breaking up the top band, patients often report significant post-procedural soreness.
Because you just stab their muscle a bunch of times.
Exactly. By using a local anesthetic like lidocaine, you achieve the exact same mechanical disruption, but significantly mitigate the post-injection soreness.
Which makes the overall experience much more tolerable for the patient.
Very much so.
That handles the immediate pain. But what about the second drug on the receipt? The 4 milligrams of Rinderon. What role does that play?
Rinderon is a specific brand name for a synthetic corticosteroid, specifically a derivative of betamethasone.
A corticosteroid. Okay, just to be clear for the listener, we are not talking about the anabolic steroids used for muscle growth, right?
No, completely different drug class.
Okay, good to clarify.
Corticosteroids are designed to closely mimic the effects of cortisol, which is a naturally occurring hormone produced by your adrenal glands.
Okay, and what do they do in a medical setting?
Their primary function is to act as a profound, localized anti-inflammatory agent.
So if the lidocaine is putting out the immediate alarm fire of the pain signals, what is the Rinderon doing to the tissue?
Think back to the environment of that microscopic traffic jam.
The gridlocked highway full of toxic exhaust.
Right. Even after the needle physically breaks the gridlock, that localized tissue has been bathing in a toxic, highly acidic soup of metabolic waste for 2 months.
So the area is furious.
It is highly inflamed.
The tissue is basically irritated from sitting in its own acid.
And that irritation triggers an immune response. The body sends inflammatory cytokines to the area, causing swelling.
Because it thinks there's an infection or an injury.
Exactly. The corticosteroid intercepts this entire inflammatory cascade at a cellular level.
It tells the immune system to stand down.
It suppresses the localized reaction, drastically reducing the swelling and preventing the tissue from becoming engorged and angry again once the lidocaine wears off.
Wow. It seems like an incredibly well thought out combination.
That's very elegant.
You numb the acute pain, you physically shatter the lock with the needle, and you suppress the residual inflammation all in one localized action.
The NCBI guidelines do note that clinicians have various pharmacological options.
Like, what else could they use?
Some might use just normal saline, or perhaps add a bit of sodium bicarbonate to reduce the brief burning sensation that anesthetics can sometimes cause upon entry.
That makes sense.
But for a severe, deeply entrenched, highly symptomatic trigger point, the combination of a local anesthetic and a potent corticosteroid is considered a highly robust intervention.
Which brings us to the ultimate benefits and why our listener experienced such a profound shift.
The 80% reduction in pain.
Right. They noted that the relief was almost instantaneous. They walked into the clinic in agonizing pain, unable to sit comfortably.
And walked out feeling like a different person.
They literally wrote, "What was my previous worrying all about?" and wondered why they had wasted so much time with basic pain pills.
It's a revelation when you finally hit the right target.
Let's validate that rapid turnaround with the underlying biology. Why did the relief happen so fast?
The speed of the release is tied directly to the sudden restoration of vascular flow.
The blood coming back.
Right. When the needle shatters the top band and the anesthetic forces the localized fibers to relax, the physical roadblock is instantly removed.
The lanes on the highway are suddenly open again.
And the immediate result of those open lanes is a phenomenon called perfusion.
Perfusion. Fresh, oxygenated blood is finally able to rush back into that starved ischemic tissue.
And that fresh blood brings something absolutely vital to the recovery process.
What's that?
ATP.
ATP, adenosine triphosphate.
Exactly.
Wait, I want to make sure I understand this. The blood brings oxygen and nutrients, which the cells use to create ATP. But what is ATP actually doing in this specific scenario? How does it help a contracted muscle?
Well, it is the fundamental energy currency of all cellular life.
Yeah.
And this is where the biology of muscle tissue gets a little counterintuitive.
Counterintuitive. How?
Most people assume that a muscle requires energy to contract, and then it simply relaxes by default when the energy is gone.
Right. Like you flex your bicep, it takes effort, you stop flexing, it just goes soft.
But on a microscopic level, according to the sliding filament theory of muscle contraction, the process of relaxing actually requires a significant expenditure of ATP.
It takes active cellular energy to let go.
It does.
That is wild.
In order to break the chemical cross bridge between the actin and myosin filaments to physically uncouple them so they can slide apart, the muscle cell must bind and expend an ATP molecule.
Oh.
If there is no ATP available because the blood supply has been cut off by a traffic jam,
The actin and myosin cannot uncouple.
they are chemically stuck in a state of sustained contraction. This is exactly what happens in rigor mortis.
Wait, really? Rigor mortis?
Yes. When a person passes away, ATP production stops. Because there's no ATP to unlock the muscles, the body becomes stiff.
That is fascinating and slightly morbid, but fascinating. So the muscle was not just stubborn, it was quite literally starved of the energy required to release its own grip.
Exactly. By opening the blood flow with the needle, you deliver the ATP, giving the cells the chemical fuel they need to finally unlock.
The delivery of ATP unlocks the fibers, and simultaneously, the renewed venous blood flow flushes out all of that pooled lactic acid and inflammatory waste.
The tissue is washed clean, the energy deficit is resolved, and the pain tension cycle is immediately broken.
That biological explanation makes the listener's immediate relief make perfect sense.
It's an instant biochemical reset.
But I also want to point out a crucial detail from their notes that highlights another massive benefit of this injection over the alternatives.
Which is?
The listener noted that in the past, when they tried to rely on general pain medication for a similar issue, they ended up developing a stomach ulcer.
That is, unfortunately, a very classic, very severe side effect of relying on oral NSAIDs.
NSAIDs being nonsteroidal anti-inflammatory drugs, things like ibuprofen, naproxen, or aspirin.
Right.
The listener wrote that dealing with chronic back pain and a bleeding stomach ulcer at the same time made them want to cry. How does a trigger point injection avoid this complication?
It comes down to the difference between systemic therapy and localized therapy.
Hey, break down the difference.
When you take an oral NSAI for back pain, you are using a systemic intervention. You swallow the pill, it dissolves in your stomach, enters your bloodstream, and travels to every single tissue in your body.
It is a shotgun approach.
Exactly. NSAIDs work by inhibiting an enzyme called cyclooxygenase, or KIO-X.
KIO-X.
This enzyme promotes inflammation, so inhibiting it reduces your back pain.
Great.
However, that exact same enzyme is also responsible for producing the protective mucosal lining in your stomach.
Oh, I see. So by shutting down the inflammation in your back, you are accidentally shutting down the protective shield in your stomach,
leaving it vulnerable to your own digestive acids.
which leads directly to gastric ulcers.
Yes. But a trigger point injection bypasses the gastrointestinal tract entirely. It is a highly localized, targeted intervention.
You are sending a specialized team straight to the problem area.
You are delivering a powerful anti-inflammatory directly to the exact millimeter of tissue that requires it, without subjecting the rest of your body, especially your stomach lining, to harsh systemic chemical changes.
Rather than carpet bombing the entire system. And there is a practical benefit here, too.
The financial aspect.
Yes. The listener noted that because TPI is an established, evidence-based medical procedure, it was covered by their standard health insurance.
Which is a huge relief for patients.
They realized it was remarkably cost-effective compared to the repeated out-of-pocket expenses for private massages or generalized electrical therapy that only offered temporary relief.
Those superficial therapies may provide temporary neurological distraction, or they might feel pleasant, but they simply do not exert enough targeted mechanical force to physically shatter a fibrotic, deep tissue trigger point.
The needle goes directly to the mechanical source of the pathology.
Yes.
So the mechanism makes sense, the benefits are clear, and the left side of the listener's back is finally conquered.
Mission accomplished on the left.
But here is where the plot thickens. According to their notes, now that the agonizing pain on the left side is gone, they have suddenly become acutely aware of a new pain creeping up on their right side.
It is a very common, very frustrating development in musculoskeletal recovery.
It has to feel so defeating. So their big pressing question for us is this: can this exact same trigger point injection treatment be used to address this new upcoming right-sided lower back pain?
The direct answer is a definitive yes. Trigger point injections are perfectly indicated for multiple points across the musculoskeletal system.
So they can just go get the right side done too.
If they have developed a new trigger point on the right side, TPI is an excellent, appropriate intervention.
That is definitely reassuring. But it raises a more complex question for me. Why is the right side hurting now? Was this not always there, silently hiding? Or is this a completely new injury that happened out of nowhere?
It is highly likely a combination of two distinct physiological phenomena. The first relates to neurology, and it is a concept known as pain masking.
Pain masking, like a loud sound drowning out a quieter one.
That is a very accurate analogy. It relates to the gate control theory of pain.
The gate control theory.
Right. The central nervous system, particularly the spinal cord, has a finite bandwidth for processing sensory input.
Meaning it can only feel so much at once.
Exactly. For the past 2 months, the massive, highly inflamed trigger point on the left side of their back was sending an overwhelming barrage of nociceptive pain signals to the brain.
It was essentially a blaring siren.
So even if the right side of the back was slightly sore or beginning to develop its own minor knot, the brain literally could not process those quieter signals because the left side was monopolizing all the attention.
Wow. So the brain naturally prioritizes the most acute, severe threat.
It triages the pain.
Once Osensei injected the left side, silencing that massive siren, the background noise suddenly became audible.
The milder pain signals originating from the right side finally had the neurological bandwidth to reach the conscious mind.
That is incredible. The brain was just triaging the pain, and we only noticed the second injury once the primary one was cleared.
Right, but there is a second phenomenon at play here too.
And what's that?
And this one is purely biomechanical. It is called compensation.
Compensation.
Think about how the listener has been forced to navigate the world for the past 60 days. They were in absolute agony whenever they sat down.
Right. When your left side hurts, you naturally try to avoid putting pressure on it. You lean away from the pain.
Exactly. For 2 solid months, this listener was profoundly altering their natural, neutral posture.
You do whatever it takes to stop the hurting.
They were likely shifting their weight heavily onto their right hip when sitting. They were probably subtly twisting their spine to protect the left side.
So they were walking and sitting asymmetrically.
And when you force an asymmetric posture for an extended period, you demand that the muscles on the opposite side do double duty.
The right quadratus lumborum, the right gluteus medius.
They were suddenly forced to work overtime, holding up the body at an awkward angle, trying to stabilize an unbalanced pelvis.
And as we just learned, when a muscle is overworked and forced to hold a sustained static contraction,
It exhausts its ATP,
the calcium builds up.
and a new taut band forms.
The traffic jam starts all over again on the other side of the highway.
Precisely. The right-sided muscles became exhausted, they developed local ischemia, and they formed compensatory trigger points.
So the pain on the right is not a random coincidence at all.
It's not at all. It is the direct biomechanical consequence of protecting the injured left side for 2 months.
So what is the concrete treatment plan for the listener moving forward?
The plan should be very encouraging for them. They need to return to O-Sensei.
Just book another appointment.
They should explain the new right-sided pain and have him palpate the right lower back and pelvis.
To find the new knots.
Once he identifies the specific locations of these new compensatory taut bands, he can administer the exact same injection protocol.
Because it's the exact same problem.
The underlying cellular pathology, the calcium lock and the ischemia, it's identical, which means it will respond beautifully to the exact same mechanical disruption and pharmacological intervention.
They already have the blueprint for success. That is fantastic news.
Very positive outlook.
But before we send our listeners sprinting back to the clinic to demand more needles, we have an obligation to zoom out.
Always.
TPI is clearly highly effective, but it is a medical procedure, not magic. To be a fully informed patient, we need to review the clinical boundaries and the potential risks involved.
Absolutely. No medical intervention is entirely without risk, and the NCBI guidelines provide a strict set of contraindications.
Contraindications meaning scenarios where a clinician will refuse to perform a trigger point injection. Let's walk through those. What are the absolute red flags that would prevent Osensei from doing the procedure?
The most immediate contraindication is the presence of an active local infection over the site of the trigger point.
Okay, that makes intuitive sense. You don't want to take a needle, push it through an infected patch of skin, and drag that bacteria deep into the sterile muscle tissue.
Exactly. It would risk creating a deep tissue abscess, which is very dangerous.
What else?
Furthermore, the procedure should not be performed on patients with severe, unmanageable needle phobia.
Oh, because they might jerk away.
Right, the patient must remain still. Sudden flinching can cause the needle to misdirect and cause unintended tissue damage.
Makes sense.
Finally, clinicians must exercise extreme caution or avoid the procedure entirely if a patient is on strong anticoagulants.
Meaning blood thinning medication.
Yeah.
Because the needle causes microtrauma inside the muscle, the pistoning we talked about.
Yes.
And if their blood can't clot properly, they could develop a massive internal bruise or a hematoma.
Exactly. But beyond those standard procedural warnings, there's a very specific structural complication highlighted in the NCBI text that often alarms patients when they first read it.
Yes, I saw that in the reading. The guidelines mention a strict warning regarding the risk of pneumothorax.
The pneumothorax risks.
A pneumothorax is a collapsed lung.
Yes, it is.
That sounds utterly terrifying. You go into the clinic to get a knot in your back, massage with a needle, and you leave with a collapsed lung.
It sounds incredibly alarming, but we really need to deeply contextualize this risk so our listener is not unnecessarily frightened.
Please do.
The risk of pneumothorax is absolutely real, but it is almost entirely associated with injections performed in the cervicothoracic region.
The cervicothoracic region. We are talking about the upper back, the base of the neck, and the musculature stretching over the rib cage.
Exactly. When a doctor is attempting to needle a trigger point in the upper trapezius muscle or the rhomboids between the shoulder blades, they are working directly over the lungs and the pleural cavity.
The pleura is the thin, fluid-filled membrane that surrounds the lungs, right?
Right. If the clinician misjudges the depth or the angle of the needle, it can pierce that membrane.
And if the membrane is pierced, the vacuum seal is broken, air leaks into the chest cavity, and the lung collapses.
Yes. That is why clinicians are trained to use highly specific techniques in the upper back, such as the pincer grip we mentioned, where they physically pull the muscle tissue up and away from the rib cage before inserting the needle tangentially.
But our listener is dealing with lower back pain.
Exactly. They are dealing with the lumbar region and the pelvis.
And the anatomical geography down there is completely different.
Completely different. In the lumbar and pelvic regions, you are dealing with very thick, dense layers of muscle, heavy fascial tissue, and the massive bone structures of the iliac crest and the lower vertebrae.
There are no lungs down there.
The lungs are located significantly higher up in the thoracic cavity. If a clinician is injecting the gluteus medius or the lower attachment of a quadratus lumborum, the risk of a pneumothorax is vanishingly small.
Okay, so given that O-Sensei has 30 years of experience and intimately understands anatomical depth, the listener can breathe easy.
Pun intended.
Huh. Yes, their lungs are safe. But looking at the listener's broader medical profile, there is another reason we want to emphasize a holistic view of their health rather than just relying on injections every time a muscle feels tight.
It is crucial to view TPI as one highly effective tool within a much broader multimodal approach to structural health.
Because looking at the notes, the listener is already managing a complex neurological profile.
They are on daily medication.
Yeah, they mentioned they currently take 150 milligrams of Lyrica, which is the brand name for pregabalin, every single day.
That's to manage cervical nerve pain and numbness in their arm, which is likely stemming from a compressed nerve in their neck.
Pregabalin is a significant medication, isn't it?
It is. It is an anticonvulsant that alters how the central nervous system processes pain signals. It is primarily used for neuropathic pain.
Neuropathic, meaning pain originating directly from nerve damage or compression.
Right, rather than nociceptive pain, which is the type of muscular pain we have been discussing today.
So the listener is already managing a delicate systemic balance with their neurology.
Exactly. TPI is a fantastic, localized tool to address the muscular ischemia in their lower back without adding more systemic drugs to their daily routine.
But the goal is to prevent these knots from forming in the first place. You don't want to live at the clinic.
The needle is highly effective at breaking the cycle, but it is the patient's daily physical habits that keep the cycle broken.
And to the listener's immense credit, they already have some fantastic habits in place.
They do. The running.
Yes, the fact that they go for morning runs is brilliant. Running provides exactly the kind of rhythmic, dynamic, blood-pumping movement that keeps the glutes and lower back muscles heavily perfused with oxygen and ATP.
It prevents the stagnation that allows those taut bands to form.
If they couple that dynamic movement with a focus on hydration to keep the fascial layers supple,
And become intensely mindful of their seated posture.
right, maybe integrating a standing desk or taking rigorous, frequent breaks to walk around.
Doing those things will actively prevent these compensatory traffic jams from forming again.
Let's summarize the journey we have been on today.
It's been quite a ride.
You, the listener, have been fighting an invisible, maddening enemy in your lower back for months. But you were not crazy. It was not just all in your head.
No, you uncovered a highly specific, biologically entrenched pathology, the myofascial trigger point.
A localized microscopic crisis where muscle fibers become locked by calcium, starved of ATP, and trapped in a toxic pool of their own acidic waste.
And you advocated for yourself until you found a highly targeted, evidence based weapon to destroy that crisis.
You utilize the mechanical disruption of the needle to pry the knot apart, combined with the chemical power of lidocaine to silence the acute pain in Rinderon to extinguish the severe inflammation.
In doing so, you completely bypassed the systemic gastrointestinal risks that previously caused your gastric ulcer.
And you are now fully armed with the knowledge that you can and should target the right side next.
Addressing the compensatory strain that developed while you were guarding the left.
It is a massive victory of patient persistence. But before we sign off, I want to leave you with one final thought to mull over.
Okay.
Something that builds on everything we have discussed today regarding the mechanics of your body.
What is the thought?
We have spent a lot of time talking about the microscopic biology, the actin, the ATP, the sodium channels.
The cellular level.
Right. But I want you to step back and think about the physical interconnectedness of your body as a dynamic suspension system.
A suspension system.
When the right side of your back started hurting the moment the left side was cured, it is incredibly easy to view that as a failure. It is easy to feel defeated and think, my body is just breaking down everywhere.
It is a very common psychological trap for chronic pain patients to fall into. They feel like their body is betraying them.
But I want you to reframe that perspective. The new pain on your right side is not a failure. It is simply your body's mechanical suspension system attempting to rebalance itself after a major structural repair.
Okay, I like that.
I want you to think about these trigger points not just as injuries, but as physical hard drives.
Hard drives. Explain that comparison.
For the last 60 days, those muscles on the right side of your back and pelvis were acting as structural hard drives. They were physically storing the memory of your poor compensatory posture.
Oh, I see.
They were storing the immense mechanical stress of holding your body upright while your left side was failing. They absorbed that burden and they locked that stress away into those rigid taut bands.
They sacrifice their own mobility to keep the overall structure stable.
Exactly. So when you go back to a sensei and he goes into that right side with the needle, forcing the muscle open and flushing out the metabolic waste with a fresh wave of blood and ATP.
He is not just fixing a sore muscle.
He is quite literally wiping the physical memory of that 2-month trauma completely clean. He is formatting the hard drive.
Wow.
He is erasing the physical record of the compensatory stress and allowing your body's suspension system to finally start fresh, perfectly balanced from left to right.
That is a profoundly empowering way to visualize the biomechanical healing process.
So go get that right-sided hard drive wiped clean. You have the biological blueprint, you understand the science of your own relief, and you are ready to sit and move without pain. We are so thrilled we could dive into your personal notes today.
It's been a great deep dive.
Keep running, keep questioning, and keep taking incredible care of that suspension system.